Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Okay, good morning, everyone, and thank you for joining us. As Alex stated, my name is Christopher Skidmore. I'm an epileptologist, neurologist at Thomas Jefferson University. I work in the Jefferson Comprehensive Epilepsy Center. What I'd like to talk about this morning is the treatment options for refractory epilepsy. The learning objectives for this morning are to be able to define medically refractory epilepsy, to understand dietary therapy options, to understand the role of resective ablative surgery, and to understand the role of neurostimulation. First, it's important for us to define exactly what is epilepsy. Traditionally, epilepsy has been defined as an individual who's had 2 unprovoked seizures greater than 24 hours apart. But back in 2014, the International League Against Epilepsy changed that classification to include a wider group of individuals. And so now if you have 1 unprovoked seizure and the probability of a further seizure is at least 60% over 2 years, then you can diagnose that individual with epilepsy. So what's an example of that? So if you have a 60-year-old female who suffered an ischemic stroke and 9 months after the stroke has a first provoked seizure that is referable to that stroke, we know that that individual's risk of having a recurrent seizure is higher than 60%. And you don't need to wait for a second seizure to diagnose them with epilepsy, and you also don't need to wait to then initiate treatment. The third indication for diagnosing epilepsy is when you have a specific syndrome. Obviously, if somebody's had their first generalized tonic-clonic seizure at the age of 18 and has an EEG consistent with juvenile myoclonic epilepsy, you wouldn't want to wait for them to have a second generalized tonic-clonic seizure. You would want to begin to treat them for their juvenile myoclonic epilepsy. So this recent definition change, I think, is helping the field to better define when we can define epilepsy. The American Academy of Neurology, the American Epilepsy Society also looked at first unprovoked seizures and came up with some guidelines and some evidence based on the evidence in the literature. And basically, you have roughly a 20 to 45% chance of a recurrent seizure at 2 years. This is level A evidence of having a recurrent seizure. Now, this is all comers. Your risk of having that recurrent seizure goes up when you have epileptiform activity on an EEG, if you've had a prior brain injury, or if the seizure occurred while you were sleeping. And so this would raise that risk and potentially raise it to the threshold of 60%. We know that antiepileptic drugs, if you initiate them after the first unprovoked seizure, will help reduce the risk of a recurrent seizure. But it's important to understand that it does not alter the prognosis or course of the disease. Antiepileptic drug medication prevents seizures. They do not alter the underlying epilepsy. And so both of these were level B recommendations from the guideline. And lastly, they looked at, does early antiepileptic drug treatment improve quality of life? And the fact of the matter is, it probably does not, because most of our seizure medications have significant side effects and can impact on individuals' quality of life. And so it really becomes an informed consent discussion with the patient to really get a better understanding as to when to treat and who to treat. So let's assume you've diagnosed somebody and you're treating them. The question is, what do you do if your medications are not working? What do you do if the individual continues to have seizures? And certainly by the time you've tried 2 antiepileptic drugs, I think it's time to really question, did you make the right diagnosis? We all make mistakes. I've made mistakes and diagnosed individuals who really did not have epilepsy. And so the first thing to question is, did you make the right diagnosis? So could there be a cardiogenic cause for this? Does the person have cardiac asystole or cardiac arrhythmia that's causing convulsive syncope that is mimicking a generalized tonic-clonic seizure? Or did the person have psychogenic non-epileptic seizures? And so I think it's important for us to step back and really verify, did we make the correct diagnosis? If you made the correct diagnosis, what kind of epilepsy is it? For instance, does the person actually have idiopathic generalized epilepsy, but you've been using a drug that traditionally only works for focal epilepsy? If that's the case, more EEG monitoring and EEG testing may give you an accurate diagnosis and then lead to better selection of antiepileptic drug therapy. And then the last question is, when somebody is failing the first or second drug, how many medications do you try? We know from a study done by Dr. Kwan and Brody, published in the New England Journal of Medicine in the early 2000s, that approximately half of individuals will be seizure-free after their first antiepileptic drug, and that roughly a third of people are refractory to treatment. Well, in 2012, they published an updated study that included more patients as well as some of the newer antiepileptic drugs. But still, after the first antiepileptic drug, roughly half of people are seizure-free, tolerating the medicine and doing well. If you then convert them to a second monotherapy, approximately 13% of the original cohort will gain seizure freedom and control. And by the time you get to your third drug, you can see now that only 3.7% of individuals will become seizure-free. And as you move beyond that third, fourth, fifth drug, the likelihood of gaining long-term seizure control is below 3%. In this study, it was also interesting to note that 25% of patients never achieved seizure freedom at all. So while we always talk about a third of individuals with epilepsy are refractory, it's 25% of them never achieve seizure control and another 10% that go in and out of seizure remission. So I want to talk today about diet therapy, surgical treatments, and neurostimulation. So we'll start by talking about diet therapy. There are 3 diets that have been utilized for the treatment of epilepsy. The first is the ketogenic diet. It's the oldest diet that's out there, and we have the most data on it. The second is the modified Atkins diet, and the third is the low glycemic index diet. So let's first talk about the ketogenic diet. The ketogenic diet was an established form of treatment for children with epilepsy. This diet consists of a diet of 90% fat. Compare that with a typical diet, which I'm going to show you on the next slide, which is half carbohydrates and about a third fat. So this is a very, very high fat consumption diet. And that because of that, there are significant downsides to this. We don't fully understand how these diets impact epilepsy. It's believed, at least in the ketogenic diet, that inducing ketosis and forcing the brain to utilize ketones for brain metabolism imparts an antiepileptic drug effect. How that truly works, we don't truly understand at this point in time. The second diet is the modified Atkins diet. This diet becomes a little bit easier to do because, again, now your fat consumption is about 60 to 65%, but you're allowed up to 10% carbohydrate consumption. And then compare that with the low glycemic index diet, where, again, your fat consumption is about 2/3 of your diet, but now your carbohydrate consumption can be as high as 30%. So if we look at this in graphical form, at least in the typical diet, roughly half of our diet is carbohydrates, roughly a third is fats, and 15% is protein. If we go to the far left now and look at the ketogenic diet, now again you have 90% fat, 8% protein, and only 2% carbohydrate. And the reality is that while this works for children, the ketogenic diet is very, very challenging for adolescents and adults because, to be honest, we have access to food and carbohydrates taste good and we want to have a wide variety in our menu. And so while parents can control small children and what they eat, it becomes harder as we get older to really control to this very strict diet. If you then compare that with the modified Atkins diet, now 60% of the diet is fat, 30% protein, and you're allowed about 6% carbohydrates. And with the low glycemic index diet, the percent carbohydrate is a little bit more liberal. So if we compare the ketogenic diet to the modified Atkins diet, and you could add a third column here and transpose low glycemic index diet, what we know is that the ketogenic diet, there's clear calorie restriction. Whereas in the modified Atkins diet, they can eat as much as they want, just as long as it's in the proper ratios. Fluids are very carefully measured in the ketogenic diet, where fluids are unrestricted in the modified Atkins diet. Typically, there is a fasting period and a requirement for an admission to a hospital for the ketogenic diet, whereas that is not required for the modified Atkins diet. So if you just look at these first four alone that I've highlighted for you, this is one of the reasons why it's more challenging to do the ketogenic diet than it is to do the modified Atkins diet. But really, the biggest things are the fact that with the modified Atkins diet or the low glycemic index diet, you can share a meal at a table with other individuals. You can eat out at a restaurant. You can buy store-bought prepared meals that are low carbohydrate or low glycemic index. And it really doesn't require intensive education. So for these reasons alone, because again, eating food is more about just nutrition, it's also about the social and community aspects of eating food. And so for these reasons alone, these diets are much more tolerable for adolescents and for adults. And that's the reason in most programs, including ours, we use the modified Atkins diet or the low glycemic index diet to treat our refractory epilepsy patients. If you look at the diets just as the 10,000-foot view, roughly 50% of patients have a 50% reduction in seizures. So the outcomes from diet therapy are comparable to add-on anti-epileptic drug therapy. So the benefits of this is you're getting the benefits of an additional anti-epileptic drug treatment, essentially, without all the systemic cognitive side effects. What are the side effects of diet therapy? In many of the studies, there can be significant constipation, especially early on when you're switching to a new diet, because of reductions in carbohydrates, and most of our fiber is found in our carbohydrate food. You can have elevated lipids, although the data on this is mixed and still remains to be seen whether this is going to be a significant problem long-term for individuals who remain on these diets. And certainly with many of these diets, it results in weight loss. And at least in the United States, where we have an obesity epidemic, this is not necessarily a bad thing, but it's just something to be aware of. So the diet therapies do work. What are our surgical options? Well, there's really two options for surgery. One is resective/ablative surgery that you can do with or without invasive EEG. And then there's the electrical stimulation or neurostimulation. And I'm going to talk this morning about the vagus nerve stimulator, the responsive nerve stimulator, and the deep brain stimulation. So temporal lobe epilepsy is one of the most common forms of focal epilepsy and is the most frequent surgery performed for focal epilepsy. It has the best data as far as seizure-free outcomes, and at least for the resective and ablative surgeries, currently has the only randomized clinical trial data available. This was a study published in 2001 by Wiebe and his colleagues, where they randomized 80 patients to intensive medical therapy or surgical therapy. So 40 were in the intensive medical therapy arm and 40 were in the surgical arm. And this was 1 year of treatment. So the surgical group got immediately evaluated and had surgery immediately and then were followed for a year. The medical group was intensively treated with other anti-epileptic drugs for 12 months. And in this attention to treat analysis, here's the event-free survival curve. At the end of 1 year, 58% of the individuals in the surgical group were seizure-free, compared to 8% of the individuals in the medical group at 1 year. And so this was statistically significantly different. If you remove some of the individuals in the surgical group who ended up not being surgical candidates, this number actually increased closer to about 70%, which is in keeping with what we know from retrospective reports, both from our center as well as many other centers around the country, that after a temporal lobectomy, roughly 70% of individuals are seizure-free at 1 year. Just as important as being seizure-free, though, is the surgical group, that there was improved quality of life compared to the medical group. And really, that's ultimately what we're trying to do when we treat our patients, is improve their quality of life. And there was a trend, although not statistically significant, that more of the individuals in the surgical group were more likely to go back to school or go back to work compared to the individuals in the medical group. And again, what we're trying to do with any of our treatment, whether it's medical treatment or surgical treatment, is really try to get individuals back to being productive members of our society and able to do the things that they want to do, which maybe include going to school and going to work. If we then look outside the temporal lobe for extratemporal lobe surgery, Engel et al. In 2003 published pooled data, meta-analysis of 239 patients, and seizure freedom for surgery outside the temporal lobe was lower at about 50%. Of that cohort, 30% of the patients who were not seizure-free did have significant improvement in their seizures, and 20% had no change. And this is not surprising, because once we move outside the temporal lobe, we're often limited by the resections that can be done because of eloquent cortex, language cortex, visual cortex, auditory cortex, motor cortex, and sensory cortex. And so we're often limited in what we can do, and so the success rate outside the temporal lobe is decreased. What about minimally invasive surgery? Many, many patients are afraid to have a traditional craniotomy and don't necessarily want to undergo that. And so over the last several years, we've been utilizing a laser ablation therapy. This is a laser probe that is placed through approximately a 5 millimeter burr hole, where you can precisely target a region of the brain to thermally ablate with a laser. And so this minimally invasive approach really has been quite revolutionary for the patients. You know, the patients are in the hospital for an overnight stay, go home the next day, have no complaints of the traditional craniotomy with all the pain that you get in the incision site. There's a reduced risk of infection as well, because now you're doing this operation through a much smaller burr hole. And so overall, from the patient's perspective, this has been well received by our patients. And so here's an example. If we look at, on the left-hand pane, you can see this black line here targeting the left mesial temporal lobe. So this individual had hippocampal sclerosis. And this black line here that I'm also then illustrating with this red marker that I put on is the actual laser probe. So this is a posterior approach to pass the laser probe down the length of the hippocampus. This is done stereotactically in the operating room. The patient is then transferred in a sterile fashion to the MRI suite, where we then can get an MRI and verify the probe placement. And then while they're actually in the MRI, we can actually turn on the laser and watch the development of the thermal lesion. So you can actually, with this device that we're currently using, you can cause a lesion of approximately 1.8 centimeters maximum diameter, but you can also make that lesion smaller. And so in this example, they had one 1.8 centimeter lesion. The probe with it was then pulled back, and a second lesion was created here. And then in the last picture, you can see this is a post ablation MRI, and you can see the lesion that has been created. So very precisely in the MRI suite, you can create these lesions, which are instantaneous because they're thermal lesions, and you can actually see on MRI live what you're actually lesioning. So our center, as well as several other centers around the United States, combined their patient populations and really presented this at a meeting in 2013, early 2013. And we looked at the 6-month outcome data on 32 patients, and roughly 60% of that group was seizure-free at 6 months, had class 1 outcomes, and then you can see the remainder of the curves here. Our center, as well as several other centers, have now published data further out, and it does appear that when you get to about a year, it appears that about 50% of the original cohort, 40 to 50% of the original cohort is still seizure-free. So while this is lower than traditional temporal lobectomy, and at least in the literature, lower than traditional amygdalohippocampectomy, which is done via craniotomy, we think that the benefits for the patients with this minimally invasive approach are quite promising. And when you do this thermoablative lesion, if it does not work, it does not preclude you from going back in and doing a traditional temporal lobectomy. So I want to now present a case to kind of illustrate what do we do when somebody really doesn't have a very good medical or surgical option, resective option. So the case is a 29-year-old right-handed male who has had seizures since the age of 10. There were no known epilepsy risk factors. His seizure semiology consisted of a focal motor seizure without impairment of awareness that involved the right lower face and hand clonic movements. He would then have postictal paresis of that hand and incoordination of that hand for several hours. The clonic movements typically only lasted about 15 to 45 seconds. The problem was he was having 15 to 20 of these per day. And if he tried to do anything with his hand, he was an avid bike mechanic, and if he tried to do anything with his hand, it would actually bring out and provoke the seizures. He was on oxcarbazepine at the time that I initially evaluated him. He had failed zonisamide, phenytoin, lamotrigine, levetiracetam, topiramate, gabapentin, and carbamazepine before he came to see me. He was currently a college student, and he was living with his roommates on campus. And he had a mild right central seventh and mild weakness and incoordination with the right hand. And so based on this history, he clearly has medically refractory epilepsy. And based on his history and exam, we're suspecting that he has some left kind of perirolandic seizure focus. So here was his interictal EEG. This is a double banana montage, right central over left central, and then some transverse chains here. And you can see right here that there is a focal spike at C3. We can also see it down here. And so he had these focal epileptiform spikes in the left central region, consistent with our history. And then we recorded several seizures. And the seizures, it's a little hard to see, but there's this fast activity that picks up here in the left central region. And you can also see it here. Picks up in frequency and then becomes obscured by EMG artifact. And this was a secondary generalized tonic-clonic seizure that you can see then is obscured by EMG artifact. So really, the only clue that we saw was this beginning of a very fast activity here in the left central region. He had an MRI performed, and in the top pane, this is a axial flare-weighted image, and on the bottom is a sagittal T2-weighted image. I'll give you a second to look at that, see if you can find the lesion. And here's the lesion. He has increased T2 hyperintensity in the left motor cortex that you can see on multiple slices. That corresponds to this gyrus here, which also looks atypical. And this would be an example of a focal cortical dysplasia. So based on this data, and the fact that we thought that his seizure focus was going to be very close to his motor cortex, if not in his motor cortex, we did an intracranial EEG study. And I'm not going to show you that data because it's too many lines to fit on the screen, but graphically, this is what it looked like. And so we put a 8x8 grid over his motor cortex, sensory motor cortex, with strip electrodes in front and behind. This is before we had stereo EEG available at our institution. And what you can see here is that the red circles are actually the ictal onset. So the outlined red, so 21, 22, 29, 30, 37, 38, 46, and 47 were all ictal onset. And this corresponded, unfortunately, with his motor cortex. So 37 and 38, 29 and 30, these were all hand motor regions. So unfortunately, his seizure onset almost precisely co-localized with face and hand motor. And so in an adult, we cannot operate in the hand motor region because if we did, we would make him permanently paralyzed if we were to resect this region of his cortex. So what did we do? Well, back in 2010, when we first evaluated him, we didn't have options for some of the neurostimulators that we have currently. And so we did multiple subpial transections over the motor cortex in an attempt to disconnect the epileptic network without causing permanent weakness. And he did have a transient reduction in seizures, But then his seizures returned to baseline. And then since then, we tried an extended release version of oxcarbazepine, as well as newer antiepileptic drugs, perampanel, clobazam, and lacosamide, all without any significant change in the seizure frequency. He was able to complete college, but because of how frequently he was having his seizures, he went to college to be a sports medicine kind of therapist and a trainer. He actually couldn't work because as he was starting to tape athletes and work with athletes, the more he used his hand, it would actually bring out more clusters of his seizures. So he was actually unemployed at this point, living at home with his parents. After the responsive neurostimulator was approved in the United States, he had a RNS implant in 2015, which resulted so far in a greater than 50% reduction in seizures. It's in addition, even though he's still having seizures, the intensity of the current seizures that he's having is reduced, and that postictal period with the paresis and incoordination of the hand was actually reduced. And he was now able to kind of get back to work. And this is a skull x-ray of his implant. And so here you can see the device is actually implanted into the skull below the skin. It's plugged into two strip electrodes that you can see here. These round contacts are the strip electrodes that are actually lying immediately over his motor cortex in his face and motor hand area. And we placed these electrodes because we very precisely understood exactly where her seizures were coming from based on the intracranial EEG data. And so this is an example of someone who in the past we might not have been able to help, but now with the advent of neurostimulation, we have options. So let's switch now for the last little bit of my talk and talk about neurostimulation. And so, at least in the United States, we have the vagus nerve stimulator, which was approved in 1997. We have the responsive neurostimulator, which was approved in 2013. We currently do not have our governmental approval for the deep brain stimulator for stimulation of the anterior nucleus of the thalamus, but it is approved in Europe as well as in Canada, and those were approved in 2010 and 2012. So let's talk about more of these individually. So the vagus nerve stimulator has been around for quite some time now, 20 years. And we've known for a long time that you implant the vagus nerve stimulator. It's an implantable device that's implanted into the left chest wall and stimulates the left vagus nerve in the neck. And through stimulating the vagus nerve in the neck, we've known that you can reduce seizures, and roughly 35% of individuals have a 50% reduction in seizures. And I'm going to show you that data in one of my last slides. Side effects include hoarseness and cough because, again, we're stimulating the vagus nerve in the neck. And so when we stimulate the vagus nerve, we're actually activating the recurrent laryngeal nerve, which can cause some laryngospasm as well as some tightening of the vocal cord. But the old system was an open loop system. So you set it to go on and off at a set frequency. 30 seconds on, 5 minutes off is a typical paradigm where it stimulates 30 seconds on, 5 minutes off throughout the day. Doesn't require any involvement of the patient, but the device always had a magnet. And so if the patient felt the seizure coming on, or if a caregiver felt the seizure coming on, they could swipe a magnet across the device on the chest, which would automatically turn it on. And there was data, anecdotal reports from patients as well as families, that when they did that, it shortened the seizures and reduced the severity of the seizure. So the company went back and said, well, are there other ways that for patients that don't recognize their seizures or don't have a caregiver, is there ways that we can actually have the device turn itself on in response to a seizure? And so what they then did was, since this device is implanted into the left chest wall and the device has a metal casing, they actually were able to program the device to monitor heart rate. In most individuals who have seizures, there's a dramatic increase in heart rate at the onset of a seizure. And so then they designed the device to turn on automatically if there was a significant change in heart rate. And so the new device that's out, this Aspire SR, is that device. It has an auto stimulation feature, which provides stimulation based on a % change in heart rate. Now, obviously, there's lots of things that we do in our day-to-day life that result in changes in heart rate, such as exercise. However, the device uses a slow-moving average, and so even if you start to exercise, your heart rate doesn't go from a resting heart rate of 70 or 80 up to 160, 170 instantaneously when you exercise. It goes up over time. Whereas when you have a seizure, it goes from 70, 80 immediately up to 140, 150 instantaneously at the start of a seizure. And so the device takes advantage of that by using this slow moving average. So it's constantly measuring what your average heart rate is and comparing it to the last couple of seconds to then determine when there's a abrupt change in heart rate. And you can make the device sensitive to pick up a 20% up to a 70% change in heart rate. And the FDA required them in the United States to do 2 trials with a total of 51 patients, simply demonstrating, does this device measure heart rate change, and does it then appropriately stimulate? And so based on that study, they admitted patients to epilepsy monitoring units where we knew exactly when the seizure started, we knew exactly what happened with their heart rate, and so we can actually then determine, based on the seizure threshold, based on the heart rate threshold, how long it took to detect the seizure and how long it took for the device to stimulate. And so if you set the heart rate change threshold to only a 20% change in heart rate, well, then the average seizure detection took about 5 seconds. If you increase that threshold to a 70% change in heart rate, so having a higher cutoff, it took an average of 26 seconds to pick up on that seizure. And there's a nice kind of linear curve here that you can see. Based on that data, then if you look at what's the sensitivity on how many of the seizures does it actually pick up for the patients, and what's the potential false positive rate per hour. And so if you set the threshold very, very high, then the sensitivity goes down. You know, it only picked up approximately 20% of seizures because some seizures didn't meet this 70% heart rate threshold. But the false positive rate was very low. Whereas if you set the threshold very low, now you're picking up 70 or 80% of seizures, but your false positive rate goes up. Now remember, we'll tolerate a certain number of false positive rates because, again, the average person, this device is on for 30 seconds, off for 5 minutes. So it's already stimulating multiple times per hour. Typically, when we start a patient off, we're setting the stimulation threshold around 40% and then moving it up or down from there based on response. So the trials that they did proved that it was safe to do this, and the safety was comparable to the normal device. They could successfully detect the heart rate change and trigger the device in response to seizures. And it was approved and is being utilized in the United States based on this data. They did not do any outcome data, though. So what we really don't know is, will this truly result in fewer seizures for patients? And we really don't know, and there's no current trial that I'm aware of being done to look at outcome from seizures with this device in. Let's switch gears and talk about the responsive neurostimulator. So the responsive neurostimulator, as I already mentioned, is an implantable device that you implant into the skull. And then you can connect 2 electrodes. It can either be a subdural strip electrode or a depth electrode, or any combination of the 2. And these electrodes are placed in or on top of the seizure onset zone. And so it becomes very important to have a reasonable high degree of certainty as to the localization of the seizure onset zone for your patient. In the trial, the pivotal trial, there were 191 patients in the trial. It was a double-blind sham stimulation trial. And basically, when the patients enrolled, there was a 3-month baseline period where we actually recorded seizure frequency. So we used prospectively captured baseline period. They then had the device implanted. So everyone had the device implanted. They gave them a month to recover from the surgery. And then there was an additional month to maximize stimulation for those individuals that were going to be in the stimulation arm. And then month 2 post-op through month 5 post-op was the blinded evaluation period. And during this time period, the individuals in the sham stimulation arm were not receiving stimulation, while the individuals in the stimulation arm were. And then eventually everyone moved into open label. And so if we look at the trial data, between the treatment group and the sham group, the percent female was normal, the same. The age was similar. The duration of epilepsy of 20 years was similar. The number of anti-epileptic drugs was similar. And localization was pretty similar as well as prior use of VNS. So it was a very well randomized patient cohort. This is the main graph from the outcome paper. And again, you can see at the time of surgery, and we've known this for a long time, after surgery, many patients have an immediate reduction in seizures, even though you did not do anything to theoretically treat the seizures. So notice that there was this immediate drop in seizures following the surgery. And really, for the sham treatment group, which was the dotted line, it really took them almost to month 4 to month 5 for them to return back to their pre-surgery baseline. Whereas in the individuals that had treatment, again, this first month was optimizing the treatment, and then this gray area was the randomized blinded period. The individuals in the treatment arm, they continue to have reduction in seizures over time. And then each of the groups went into the open label phase, and then both groups started to see continued reduction in seizures. So based on this data, if you look at both the pivotal trial and the feasibility study, 230 patients enrolled, 191 patients still actively being followed at the time of this publication. The median percent reduction at year 3 was 60%, and at year 6 was 66%. This is both adjusting the device as well as adjusting antiepileptic drug medications. And the responder rate, those individuals that had a greater than 50% reduction in seizures, was pretty comparable, 58% and 59% at year 3 and year 6. The safety, is this device safe? The intracranial hemorrhage rate was 4.7%, which was well within the margins expected for implanting a device in the brain. The implant site infection was 9.4%, again, expected for these types of devices. And 4.3% of these individuals over the course of follow-up have died, 2 from a suicide, 1 from status epilepticus, 1 from lymphoma, and 7 from suspected sudden unexplained death in epilepsy, which is SUDEP. Last device, the deep brain stimulator, and this was a trial where we stimulated the anterior nucleus of the thalamus. Again, the pivotal trial, similar number of patients compared to the responsive nerve stimulator trial, 110 patients. This was also a double-blind sham stimulation study. Similar trial design, although one major difference. They only allowed a 1-month post-operative period recovery. And so they actually started stimulation 1 month post-operative, and that's the beginning of the randomized phase. And remember, if I showed you, it took the sham stimulation group in the responsive nerve stimulator trial roughly 4.5 months to get back to their original seizure frequency. And so that can impart a false negative trial design. So we have to be careful about that in future trials, that we probably need to give several months of post-operative recovery before we actually measure true outcomes, whether it's stimulation or any epilepsy surgery. But they did a similar 3-month randomized time period where stimulation, and then they went into open label. Again, patient populations were very similar in age, sex, years with epilepsy, number of baseline medications. So again, this trial data is very similar to the trial data, and I'm not going to go through the whole thing, but again, about 38%, between 38 and 50% had prior VNS. About a quarter of them had prior brain surgery, and roughly 50%, a little bit more than 50%, had temporal lobe epilepsy. So very similar cohort to the responsive nerve stimulator trial. And here's the graph from their outcome paper. And so again, you had this 1-month post-operative period, and then as you entered the randomized trial period, you see over time the sham group approaches, but doesn't really get back to that original seizure frequency. They still had a 14% reduction. But again, I really wonder if we shifted this to a 2-month start from the time of surgery, would the sham group have actually gotten back to their original seizure frequency? Where with the stimulation group, there was an average of a 40% reduction in seizures at the end of the blind period. And so if we look at this, first look at the long-term treatment outcomes in 105 patients, 30 of them discontinued. The median percent reduction in seizures at 1 year was 41%, at 5 years is 69%. And the responder rate, again, those individuals that had a 50% reduction in seizures at year 1 was 43%, and at year 5 was 68%. Side effects, about 20% of individuals had paresthesias that they reported. They had pain at the implant site in about 10%. The infection rate was very similar to the responsive neurostimulator at 9.1%. The hemorrhage rate was almost identical at 4.5%. And the death rate was also about the same at 4.5%. And in their group, they had 1 suicide and 4 sudden unexplained death in epilepsy. So again, both of these patient populations are very severe, very refractory patients. And we know in those individuals that the risk of SUDEP is 1% per year. So again, these SUDEP rates are to be expected. If we look at all the trials then together, all the neurostimulator trials, the top 2 are the vagus nerve stimulator, the original trials, the RNS trial and the DBS trial. Again, in the actual blinded phase, the VNS had roughly a 25 to 27% reduction in seizures during the blinded phase. RNS was right around 38%, and DBS was at 40%. The responder rate, again, those individuals that had a greater than 50% reduction in seizures, was 31 to 23% in the VNS trials, was 30% in the RNS trials. They didn't measure it in the DBS trial, but the responder rate at 1 year was measured in all those trials. And again, it was about 35% for the VNS trials and 43% for each of the RNS and DBS trials. And so the data is slightly better for the RNS and DBS stimulators compared to the VNS, but really all 3 of these stimulators are effective for the treatment of medically refractory epilepsy. So then the question becomes, if they're all effective, how do you choose between these? If you have access to all 3 of these devices, how do you choose? The responsive neurostimulator system really is the system that requires the greatest amount of patient participation. The patient actually has to download their data from their device on a regular basis to upload to the cloud for you, so then the device can be customized to their individual seizures. The responsive neurostimulator is a closed loop system, meaning that the device is stimulating based on the patient's specific seizure pattern. And so you really require the patient to upload their data for us to then customize the device for them. And so that becomes important, that you really need to choose a patient, A, that has no more than 1 or 2 seizure foci, that you are very highly confident that you know where their seizures are coming from in the brain, because you can place electrodes there, but also in an individual that you know is going to be able to really reliably download data and show up for follow-up appointments. Whereas the vagus nerve stimulator and the deep brain stimulator, because these are devices that you simply set and the patient goes home, and when they're at home, they don't necessarily need to do anything with that device. They just need to come back for regular follow-up visits for further programming. These devices, I think, are a little bit easier to implant in individuals where we really don't have a well-defined seizure focus, where we can't point to 1 or 2 spots, and also where perhaps the individual is going to be a little bit less reliable, and or there's a caregiver not there to kind of assist them in downloading information from the device. And so that's kind of how I kind of try to pick and choose patients for these different neurostimulators. So to conclude my talk this morning, roughly a third of patients with epilepsy will not respond to medications. And really, it's by the time you're getting to your second and certainly by your third anti-epileptic drug, you really need to question, did you make the right diagnosis, and verify the diagnosis? And if they're not responding to treatment, really look at other alternative options, including diet therapy, resective or ablative epilepsy surgery, or neurostimulators. Diet therapy can be an alternative. It does take a certain individual because they have to be very regimented with their diet and stay on it just like a drug. Resective surgery is very safe and very effective for many individuals. Minimally invasive surgery is something that we're certainly helping to pioneer and move forward. And I think it is going to be the wave of the future for some individuals, and certainly is an option currently at our center. And neurostimulation, now we've had 20 years of experience of utilizing neurostimulation to treat and modulate the brain. And it is a great option, again, for those individuals that are not responding to medications and don't really have any other surgical options. So I want to thank you for your attention. I'll be more than happy to entertain any questions.